postoperative nausea, emesis, abdominal distension, and obstipation.
Dudes, we're back!
If you haven't already, check out the previous video on SBOs. There's some seriously important information in that sketch. We are starting here from where we left off. We've just finished up with SBOs, and we're moving on to a very similar related condition, ileiasis. Let's meet our case. Felicia Falcon is currently admitted to the hospital after having surgery for perforated appendicitis. She reports significant PO intake the first day after surgery because she hadn't eaten for several days prior to the surgery. Yesterday, however, she was a bit nauseated and didn't eat as much, and today she can't tolerate anything. Now she's bloated, nauseated, and throwing up, and has not passed gas or had a bowel movement since surgery. Her abdomen is very distended, and though the surgical incisions look normal, not bleeding or infected appearing, she has no bowel sounds that can be heard. She reports that a high amount of opioid medications have been required to manage her pain. We were asked what the next most appropriate step in management is. Oh geez, she's got a bowel obstruction just like our mom. Quick, get her back to surgery. I mean, come on, she just had surgery, and we just talked about adhesions causing obstructions and stuff. Wait, hold on. That doesn't seem right. SBOs don't normally happen so fast after surgery, do they? Is this ileus thing that we're going to talk about something that looks like an SBO but actually is different? That sounds more familiar. Let's drop back in. Ileus can be thought of as a functional obstruction. There's nothing really blocking the way for fluid to flow through the GI tract, but the bowel acts like there is. Think of it like the wheels falling off this skateboard, making it functionally not able to move, just like the paralysis of the intestines. In fact, ileus can also be called a paralytic ileus. So our clinical patient, Felicia, could have this going on. Symptoms are very similar to SBO. Nausea, emesis, abdominal distension, diffuse abdominal pain, none or minimal flatus or stool, and inability to tolerate PO intake. Physical exam is also similar to SBO, with abdominal distension and tympany on percussion. Check and check for Felicia from our clinical case. Looks like we're on the right track. But hang on, we were just talking about the hyperactive bowel sounds in SBO. But remember from our case that she had no bowel sounds? What's up with that? Hypoactive or absent bowel sounds are a major clue to the correct diagnosis. In ileus, bowel sounds are hypoactive or absent because the barrier to passage of bowel contents is due to decreased functioning and contractility of the bowel. Remember that bowel sounds were more active in SBO trying to push past the physical obstruction. Postoperative ileus is the most common cause of ileus. This occurs with recent surgery, particularly abdominal surgery, and may last hours to days. So not only does Felicia have this, but she's got the most common sort of it, postoperative ileus. Postoperative ileus is the natural response of the body to manipulation of the bowel. Once it gets touched, it freezes up, kind of like a sea anemone. And sometimes it can take a while to start up again. The physiology of this includes local inflammatory mediators and increased splanchnic, or sympathetic, innervation of the bowel after surgery. The more manipulation, the more ileus that can be expected. Like this zombie graffiti thoroughly running his own bowel before taking a big ol' bite out of it. Another very common postoperative cause of ileus is the administration of opioids, which cause decreased gastric and small bowel motility. Remember all those opioids Felicia from our clinical case said she needed? This was probably a huge contributor to her ileus. The term prolonged postoperative ileus is applied if the ileus lasts more than 3 to 5 days after surgery. This scared out of her wits mother over here is going to help demonstrate how to prevent ileus as she tries to prevent her daughter getting hurt on her first day skateboarding. Strategies to prevent postoperative ileus include using an epidural with local anesthetics and using other non-opioids like NSAIDs to reduce need for opioids, limiting intraoperative fluid administration to decrease the amount of third spacing to the bowel, using a minimally invasive approach, or at least a smaller incision, and limiting manipulation of the bowel during surgery. There are also many non-surgical causes of ileus. Not only can these cause ileus on their own sometimes, but they really can contribute to prolonging an already present ileus, such as postoperative ileus. Many chronic medical conditions can cause ileus: diabetes, stroke, spinal cord injury, Parkinson's disease, epilepsy. Many conditions causing nerve dysfunction may experience ileus as a symptom of their disease. In diabetes, it's important to remember that diabetic gastroparesis is paralysis of the stomach related to nerve dysfunction, whereas ileus typically refers to the small bowel. Medications can also cause and contribute to ileus. We've already touched on opioids. Others include those drugs with anticholinergic effects, such as antihistamines, antiemetics such as prochlorperazine, some SSRIs, TCAs, and antipsychotics, and medications that affect muscle, like calcium channel blockers and muscle relaxants. Chemotherapies can also cause ileus. Acute conditions, which may be related to surgical complications, can also cause ileus. Blood within the peritoneal cavity, also called hemoperitoneum, is quite irritating to the peritoneal surfaces and causes inflammation and then ileus. Retroperitoneal blood may also result in ileus. Think of your post-op patient with a slow venous ooze into his abdomen, or that trauma patient with an intra-abdominal or retroperitoneal hemorrhage. Anything that causes inflammation in the abdomen or irritates the peritoneum has the potential for causing an ileus. This includes a multitude of infectious conditions, like gastroenteritis or perforated appendicitis, perhaps, like from our clinical case. There's also diverticulitis, anything that can cause an abscess, and even anastomotic leaks. In fact, an ileus may be the first sign of a leak. Other infectious causes can be acalculous cholecystitis or spontaneous bacterial peritonitis. In the case of postoperative ileus, it's imperative that when evaluating your patient, that you rule out postoperative complications that could be causing ileus. That means postoperative hemorrhage, development of abscess or anastomotic leak, or the ever-terrifying ischemia and perforation. And here we are, folks. The answer to our clinical question. Of course, we'll need to manage Felicia's symptoms too, but in a postoperative patient, it's so important to rule out anything malicious going on. Leak at the staple line, intra-abdominal bleeding, iatrogenic injury during surgery. Let's get some imaging. Like start with an upright abdominal x-ray followed by a CT scan. And while the x-ray techs are on their way, let's finish up this sketch. Severe systemic illnesses causing systemic inflammation can also cause ileus due to significant peritoneal inflammation. These include pancreatitis, sepsis, severe burns, etc. Bowel ischemia may also cause ileus, and sometimes an ileus is the first sign of it. Electrolyte abnormalities and uremia may also cause ileus. In all of these cases, the only way to resolve the ileus is to identify and treat the underlying cause of the ileus. Identification of these may be as simple as careful monitoring of serial labs. CBC for the hematocrit and hemoglobin may identify hemorrhage, WBC count for infectious processes, including developing ischemia, and electrolyte panel for the potassium, magnesium, BUN, and creatinine levels. Determining whether the patient's symptoms are due to an ileus rather than a small bowel obstruction may be as easy as imaging. In ileus, typically the whole GI tract from the stomach to the rectum is involved and therefore dilated. The small bowel is also dilated, but is usually air-filled, in contrast to an SBO where there's both air and often significant fluid. The colon may be dilated with air or stool. In SBO, remember that the stomach and bowel will be dilated until the point of the obstruction, and everything distal to the obstruction is usually collapsed. A dilated colon is a helpful sign that can point you towards an ileus and away from a small bowel obstruction. See, I told you imaging was the right step for Felicia from our clinical case. Her imaging results are in, and as expected, they see a dilated stomach, small bowel, and plenty of air and stool in the colon and rectum. And no evidence of anything scary going on. Wow, she is definitely FOS, full of stool. What? What word did you think I was going to say? Treatment of ileus should be supportive, like the treatment of an uncomplicated SBO. Patients may require bowel rest with NPO status, intravenous fluid support, and nasogastric decompression to control their symptoms. At the same time, you should treat the underlying cause of the ileus that you found on the workup, as we discussed, or the ileus will not resolve. In our clinical case, as Felicia's postoperative condition improves, the ileus should go away on its own. We can support her by changing her pain control to Tylenol and Motrin, getting her out of bed to walk around, and making her NPO to start with, as well as IV fluids. It's a bit early for an NG right now, but if she doesn't get better, NG would be the next step. Finally, you must rule out a true bowel obstruction in patients suspecting of having an ileus, Because a non-resolving SBO will require treatment to prevent perforation, whereas ileus can persist for some time without causing perforation. You may also need to obtain a CT scan and/or perform a small bowel follow-through in order to differentiate an ileus from a small bowel obstruction.
Dudes, we're done.
Great job, everyone. We are all finished up with ileuses. Ilii? Ileoctopi? Still not sure how to make that plural. In any case, let's review. While similar in presentation to SBO, with nausea, emesis, abdominal distension, abdominal pain, and constipation or obstipation, ileus is a functional dysmotility rather than a mechanical obstruction. Postoperative ileus is the most common type, and may be due to bowel manipulation during the surgery or opioid use for postoperative pain. A prolonged postoperative ileus lasts longer than 3 to 5 days, and may be prevented by usage of opioid-sparing pain control such as epidural with local anesthetic or NSAIDs, limiting fluid administration as possible, minimally invasive approaches, and limiting manipulation of the bowel. Non-surgical causes of ileus are numerous and include diabetes, neurological disorders, medications, particularly those with anticholinergic effects, hemoperitoneum or retroperitoneal hemorrhage, intra-abdominal inflammatory or infectious processes, or electrolyte abnormalities. Treatment is supportive with IV fluids, electrolyte repletion, and may require NPO status and NG tube decompression, as well as treatment of the underlying cause. And finally, you must rule out SBO when evaluating a patient for possible ileus. And I'll end this video with a question. What's Tony Hawk doing right now?